Recording in progress.
Hey.
Good afternoon. Thank you so much to everyone online and in person. This is Foundations of Global Health in conjunction with the International Orthopedic Trauma Collaborative. I am Alexa Smith and I am with the Office of International Programs. I am the Educational Exchange Event Program Manager. Just a little bit about our series. Global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions, involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual-level clinical care. And that comes from the Consortium of Universities for Global Health. Global health is a varied and rich discipline to which many healthcare providers, researchers, and faculty aspire to being professionally engaged. With our being a globally connected world, this ongoing programming through the Office of International Programs is designed to feature those in our KUMC community engaged in the field of global health. KUMC's faculty, researchers, and clinicians, our international partners, and our community partners. This series is meant to provide a platform for both presenters and participants to participate in conversations while developing foundational knowledge and exploring best practices for engagement in the discipline of global health. We will be back on September 2nd over in HEB. So I'll turn it over.
Thank you. Right. Everybody, good afternoon. So my name is Michael. Michael Brayman. I'm a fourth-year medical student, and I've been involved with this group with ATI and IOTC since I was a first year. So I'm just going to speak a little bit about my experience and kind of highlight some of the problem statement from the medical student perspective as well, and then we'll go into Dr. Heddings is going to delve into more of like kind of the general problem statement and what we're looking to do and accomplish as a group. So something that's really interesting, and maybe you guys have heard about it. I know, talking about burnout is something that is fortunately gaining more traction. Kind of normalizing and destigmatizing, talking about physician wellness and mental health. Is becoming a more and more important subject. I think that was really highlighted by the COVID pandemic, of course. And another thing that we think a lot about is like burnout with respect to kind of medical students. Medical school and medical training is a very challenging, kind of lengthy process. And one kind of unique thing that you might be aware of, or maybe you're not, but something that has been studied is kind of there's a unique phenomenon that happens across the medical training. So like particularly in the transition from you guys are currently in your didactic years for a lot of you in the first and second year, and then you'll transition to the more clinical-based years in years 3 and 4. And a unique phenomenon that happens is that we actually see empathy kind of declines for a variety of reasons, and that can be related to burnout, that can be related to things beyond, kind of recognizing how much of healthcare, particularly in the United States, can end up being beyond our control, whether that's related to insurance or kind of other logistical things, kind of the social determinants of health as well. And kind of the toll that can take on kind of clinician wellness and those types of things can really lead to a decline in empathy. But uniquely, and something that is so important to our group, is there's also been studies that have demonstrated that participating in international travel, international health programs has actually been shown to curb that decline in empathy. So engaging in a program like ours or in international travel, international collaboration outside of yourself and kind of can really recenter kind of your focus and kind of really clarify a lot of the reasons that we all kind of chose to pursue a career in medicine. So that's one of the things that we really focus on when it comes to ATI, and something that Dr. Heddings is so passionate about in terms of kind of ensuring that we have great medical students and great medical student experience internationally. Being able to conduct research, collaborate with our international peers and the African fellows that come and train in our trauma fellowship. Really getting that exposure really just kind of reminds us as students kind of all, the things that are incredibly valuable about being in a career in medicine. Because I think there's few things that are like it. It's incredible. It's a great opportunity that we all have. So speaking of some of my experiences with our group, an opportunity that basically to clarify some of the kind of the logistics of our group, we normally take between 3 and 4 students every year. So my cohort has 3 students, including myself. And then I think most of our years have 3 students. So we'll be looking sometime in the kind of winter timeframe for a new cohort of M1s. So keep that on your radar if you know if kind of our message resonates with you and you think that this is an experience you might be interested in. And then one of the things that we really focus on is being able to not only collaborate with our international peers. We've got peers that we work with in Romania. We've got folks that we work with in Ethiopia and Zambia, kind of all across the world, and we focus on different problems all through the lens of orthopedic trauma. And one of the things that we really focus on that Dr. Headings really emphasizes is the ability for medical students to actually be able to travel and really have, an incredibly unique experience. There's not many medical students that get to have that experience. So myself and my cohort all went to Romania to a town called Botoșani where we collaborated with some peers that we have both in orthopedic surgery and in anesthesiology. The project that I focused on, which is really unique with respect to Romanian kind of medicine compared to our care in the United States, is how they manage perioperative pains. It's a huge problem when it relates to not only orthopedic surgery, but also any surgical intervention. Pain control is a foremost consideration. And we know, things like particularly in the setting of orthopedic trauma, being able to access early rehabilitation and physical therapy is really critical, really important when it comes to outcomes after orthopedic surgery. And being able to control pain is one of the main barriers to allowing people to participate in those activities that we know that will improve their outcome. And then obviously that is kind of framed in the United States additionally by the opioid epidemic that we've been kind of struggling with and working through. That has, a longer history that we'll cover in kind of future lectures. And uniquely in Romania, they're incredibly sparing when it comes to opioid medications. I think I worked with probably about 10 clinicians that I spoke to while I was there about how they manage perioperative pain. I specifically asked the question to all of them, how over the course of your career, how many kind of outpatient prescriptions for any sort of opiate medication, like at discharge. So it's pretty common that we will send folks home with, a short duration script for opioid pain medication. They told me from all of those people, they said once in their career they've seen it. So it really just kind of spurred this question of how can we learn from our colleagues with respect to how they manage perioperative pain, and how can we take those lessons learned and help care for our patients here in the United States. So that has spurred a bunch of research, including kind of a opioid sparing trial that we're conducting here on campus, as well as some literature review into a novel medication that they use that we actually don't use in the United States. So just kind of being able to collaborate broadly with these international colleagues and just kind of going into those endeavors so open-minded and kind of ready to learn has been an incredible experience for me. And kind of just in closing on my experience, the last kind of thing that I would share with you is one of the things that we were actually just discussing kind of before this talk that is so unique and really kind of brings you back to the roots of kind of why you're pursuing a path in medicine, is being able to collaborate internationally and just really, as you interact with international peers and colleagues in medicine, you just find that regardless of the circumstance, regardless of the clinical setting, that everyone's focus is just on their patients and how they can take good care of their communities. So that's just a really incredible message. We can often get caught up as students and thinking about the next board exam, thinking about step 1, step 2, but being able to have these experiences and be really present and kind of allow that to reflect on kind of your path in medicine has been a tremendous thing for me. And I know I speak for kind of all the students in our program who've had kind of similar experiences, how incredible that's been for us in kind of shaping the clinicians we want to be in the future. With that, I'll turn it over to Dr. Headings. If you guys have any questions about the program afterwards, or you ever want to send me an email, ask a question, feel free. Again, my name is Michael Brayman. Email is mbrayman2@kuc.edu. With that, I'll turn it over to Dr. Headings.
Thank you so much, Michael. That was great. And you're going to make a great physician. Super proud of you and your entire class. Well, let's get into this. So we're going to talk about orthopedic trauma. I don't know where you sit in terms of medicine. I know for me, when I got into medicine as a medical student, I didn't even know what orthopedics was. Honestly, I did not have family in the field of medicine. And when I was assigned an orthopedic rotation, I was angry. I said, what is this? I tried to actually get switched out of it. And I ended up loving it, obviously. But So, but why are we talking about what is orthopedic trauma? Because here's what I want you to see. Okay, I want you to see this. I want you to see how you can take your career, because you can think of me as a mid-career surgeon. I want you to see how you can take your career and pursue your passion. Right now, you're just trying to get into medicine. You don't even know necessarily where you're going. But I want you to be a good physician. We want to turn out good physicians. We need good physicians in this country. So thank you, as I said, thank you for taking the time to be here. I hope this is worth your while. And I want you to get something out of it. So here's something I want you to see. This is a paper. It's a 2022 paper, and it's titled, "What Happy Physicians Have in Common? A Qualitative Study of Workplace Perceptions of Physicians with Low Burnout Scores." What is burnout? It's a phenomenon characterized, so I took this out of the introduction, characterized by the constellation of depersonalization, emotional exhaustion, and feelings of diminished personal accomplishment. High burnout rates have plagued service professions for decades, but recent reports show that the incidence of burnout in the medical field is rising at an alarming rate, with reported prevalence of greater than 50% in physicians, greater than 50%. In comparison, the average burnout rate for general full-time professionals is about 23%. Why is that? What's happening? Well, I've watched this. I've been in the field now since 2001. When I started out, I owned my own practice. When you own your own practice, you say when you go on vacation, you get to say who you treat and who you don't treat. You actually have, I had authority if somebody didn't have insurance and I wanted to do like work here, charitable work here, I could do it. I could bring in the patient who couldn't pay. I could forgive their bills or I could diminish their bills. Well, you felt you didn't have to travel somewhere across the world to do some type of good work because you ran your practice. You controlled how much profit you made. You know, if you wanted to see nothing but paying patients, you could do that. But if you wanted to, accept some profit loss in order to do something charitable, you had that power. But now most physicians we're employed, right? And we work for health systems. And I can tell you, that's a much different type of life. Every single penny I spend, whether it be in the operating room, on an implant, how much time I spend with my patients, what my patients think in terms of, how my practice runs, even though I don't run my own practice anymore. I get all these scores, and I'm compared to all these physicians across the nation. And then I never used to have conferences on how to bill and document, but these are a regular occurrence now. Who here got into this because you want to bill and document like nobody else? Who here got into this because you want to help people and make people better? I assume that's why you're here. It's a battle you have to fight, right? And if that's taken away from you, and you become a tool, you're not that, but you're a tool of the system. What's that going to do to you? You're going to burn out, right? So there were 6 major themes observed in happy physicians. And they included variety in work, a sense of empowerment, connection with patients, visible impact. You could see you were making an impact. Feelings of community with coworkers and colleagues, and experiencing a sense of calling or a purpose. You've got a purpose, right? So I'm going to shoot. Now I feel that. I do feel that in my career, but it's easy for a surgeon who's, I think I've been here a while in a health system to kind of feel that way. But starting out, it's, particularly in a big health system, you can get swallowed up. But I want to show you, because I would define myself as a happy physician. That's how I define myself. And I'm going to show you one of the pieces of that recipe that I think has made me a happy physician, because it allows me to pursue that very thing that you guys all nodded your head to. It allows me to help people out and make the world a better place. So what's the African Trauma Initiative? We're going to talk more about this in the next lecture, but it's basically an American university's response to a trauma epidemic that's occurring in part of the world in Africa, right? Where trauma is concentrated to the highest level in the world. And we want to do this by developing self-sustaining orthopedic trauma centers in Africa. I did international work, and what started this whole thing was I was asked to go to Ethiopia just to do some teaching on pelvic and acetabular trauma. And when I was there, this gentleman right here on the far left, Dr. Solomon, said to me, "We don't need more Americans and Europeans to come to Africa to operate. Just teach us how to do this." And so he said, "Develop a fellowship program. We'll come train with you, and then we'll go back and we'll teach our people." I was like, "Man, let's do that." So anyway, that's how we got there. But when we're talking about international medicine now, so to get into that, because not everybody's going to be working in Ethiopia necessarily, but or when we talk about you having purpose or calling or impact, you don't have to discover a cure to a disease or develop a new surgical technique to have a huge impact on the health of others. You don't, right? You don't have to come up with a new vaccine. How can you have an impact? Well, think about this. The impact of a discovery or advancement in medicine doesn't just end when it reaches your sphere. Okay? It doesn't. And so in America, we have lots of medical technology that we take for granted, but there's parts of the world that don't have that at all. So if you think about it, if you can just extend to other parts of the world that don't have what we have, you can have a tremendous impact. These are just some people who make up the African Trauma Initiative initially. Students play a huge impact in this. When you travel overseas, you act as ambassadors for the University of Kansas Hospital. We put a lot on you in terms of like what we expect from you and ask of you. And so this whole thing was started with, here's Jack Nolte, here's Jack Harris, and here's Jonathan Dahlman, all orthopedic residents. Jonathan's in our program, but they were some of the 3 people that helped start this whole thing. This is Adam Goodyear. He's a joint replacement surgeon in Lawrence. Kim Connolly-Holland, she runs the Office of International Program, without which this whole thing never would have happened. And then you'll see we've got a lot of people here all over from KU, from the School of Film and Media, Professor Matt Jacobson. He's helped us develop a documentary. Where's Bacher? There he is. Bacher in the back's our lead producer on our documentary. Here he is right here. We've been putting our documentary about the trauma epidemic out on the film circuit. We've won some awards. Darren Seppi, a physician from Cameroon, also got his MBA from the School of Business at KU. We have some architects from KU, Frank Zilm, another architect from KU here, Ken Sprinkelmeyer. So lots of people from KU involved. So, and other medical students that you may know down here. So yeah, it's kind of a big thing. It's a big thing here. So we're going to get into now what is orthopedic trauma. So let's first just start out with what is trauma, because that's kind of a confusing word. If somebody says, "Man, I've experienced trauma," it's used in a lot of different ways. But we're going to get to the origin of the word, and the origin of the word comes from ancient Greek, meaning a physical wound. If you look at the Merriam-Webster definition of trauma, first thing that comes up, an injury, such as a wound to living tissue. That's what we're talking about. Another would be like a disordered psychic or behavioral state resulting from severe mental or emotional stress. Studying for some test in medical school, getting the results of that test that you weren't necessarily wanting. You've probably all experienced that, or you're going to experience that. Unfortunately, it's just a part of the medical school experience. But we're not talking about a disordered psychic state. We're talking about this number one thing, an injury. An injury, such as a wound to living tissue. This is the type of trauma we're talking about. So injuries, how much are there? How much injury is there in the world? How much trauma is there in the world? Well, it's about, if you look at the deaths in the world, about 10% of the deaths in the world are due to trauma. 10%. So about 5.8 million people die due to trauma every year. But here's what's interesting about it. 93% of the deaths that occur from trauma occur in low to middle income countries. 93%. And we're going to go through why that is. But remember that thing that I said, that the impact of a discovery in medicine doesn't end when it just reaches your sphere? That tells you something. You can save a lot of lives if you can extrapolate this technology to other parts of the world. In addition, deaths due to trauma are increasing, and we'll kind of talk about why that is, with a 40% rise expected, by the year 2030. This graph that I have up there just talks about what's killing people, okay? And it's important to talk about HIV, malaria, TB, they're lower than injuries right now, but that's because there's been concerted efforts by the world to combat these diseases. HIV, one of the countries we work in, Zambia, 1 in 3 people in Zambia died due to HIV AIDS at the height of its when it was really affecting people in Zambia. And I will tell you that if you go to that country, people that live through that, it's like they cannot do it. They have to talk about it. At least someone lost a family member from it. But I think that number right there shows, you can have a concerted international effort and it can have an impact. But right now, HIV, malaria, TB, the number of deaths due to that, less than injuries. Ischemic heart disease, cancer, they top out the death rate in terms of over injuries. But there's some important things that I think we need to recognize about this. So, who is ischemic heart disease affecting? Who is cancer affecting? And who are injuries affecting? Well, trauma, it's the leading cause of death among those 35 to 45 years of age and younger. So 35, 45 and younger, that's who trauma is hitting. This is a chart of disability adjusted life years. If you look at disability in the world, what's causing the majority of the disability? It's injuries. Right? Why is that? If ischemic heart disease and cancer is killing more people, then why are there more disability adjusted life years? Why are there more people disabled and affected by this and a greater burden on society because of injuries? And here's why. If you look at who sustains or who develops, say, cancer and dies from it, that average age is in your 90s. Well, what's the effect on society if somebody dies in their 90s? What's the effect on society if somebody dies as a young mother in her 30s? It's profound. What's the effect on society if a father who supports his family can no longer work and he's disabled? It's profound. Does that make sense to you? So why I'm taking time to talk to you about that is because sometimes people will throw out numbers and say more people are dying of heart disease, therefore, we really need to invest in that. Well, the average age of like a myocardial infarction, I think it's in the 70s. You can check me on that. I don't know exactly. I somehow lost that fact in here, but it's older, right? Look, the effect of grandma having a heart attack and requiring oxygen is not the same as mom dying and you've lost a mother. It's two different things. So trauma affects a younger population and it results in a tremendous burden on society. It's the major cause of disability in low to middle income countries. And that number you saw, where 93% of the deaths that occur in trauma occur in low to middle income countries. For every one death that occurs due to trauma, there's 50 more people disabled as a result of trauma. So those numbers are quite high. Now, where does trauma occur? This is it's a heat map. It comes from the World Health Organization. You can see that down here. And the darker the green, the higher the concentration of road traffic accident mortality. And you can see most of that's concentrated in Africa. Now, there's a reason why that is, and we'll talk about that in further lectures. But this is where it's occurring. So it's occurring here. And what's causing it? If you want to treat trauma, you have to understand what's causing it. And this just shows a proportion of deaths that result from trauma. 65% of trauma-related deaths are from road traffic accidents, conflict-related violence, self-harm, and falls. Those are the big things that are killing people. And the conflict-related violence number is actually much higher. But the way these numbers are obtained is you'll have like this organization that will go to governments and say how many people died of conflict in your country. Well, you can imagine in a country where there's civil war, those numbers they're not accurate. So I'll tell you, this number is actually, for everything that's written about in terms of people dying of trauma, particularly conflict-related violence, that's not accurate. How's trauma treated? So as you get into medicine, you're going to see there's two major types. There's two major types of pathologies in terms of the way we treat them. There's like a medical form of treatment, and then there's a surgical form of treatment, right? And you'll see. Look at some of these injuries I show you. You cannot solve this by giving somebody IV fluids and a pill. That's not going to solve it. They need surgery, right? So we're talking that trauma is in large a surgical disease. It has a medical component to it, but it is a surgical disease. If you want to treat it, you've got to have a hospital that can do surgery, okay? So how do we come together to treat somebody who's been broken? A body that's been broken, what do? You need a surgical team. And so as an analogy, this is how it was explained to me as a medical student. If you have a house that's been damaged, like down to the right over here, you've got a house that's been damaged by a tornado. Up to the top right, a plane plowed into a house. That center picture with the older lady in front of it's a lady in Ukraine from a bombing. So you can think of that as penetrating trauma. But what do? If you're going to put a house back together, you need framers, right? You need foundation repair specialists, if it's bad enough. You need an electrician. You need all these different specialties. You don't say, my house is blown over, I just need a house person. It takes a lot of skilled labor. And you can think of, that's what a trauma center does with the human body. You can think of the electricians as maybe the neurosurgeons, the carpenters, that's the orthopedic surgeons. The foundation, to me, I think of the foundation as the cardiothoracic surgeons, right? If somebody's heart's going out, they're not. If you don't have that, they're dying, right? So, and it's similar in a house. If a foundation's out, there's nothing that will solve that house problem. But just think about that. So that's how we solve trauma. Is you have a team of subspecialists come together and reconstruct this human body that's been broken. So what's orthopedic trauma surgery? Well, it's a field of study focused on reconstruction of the musculoskeletal system following traumatic injury. So here's a picture of one of my patients who had a head-on collision on I-70. And out of that, she got this femur fracture, she got that femur fracture, she got this bone forearm fracture. So her legs went into the dashboard. Her forearm, went into her steering wheel. What do you do for that? Well, put a rod in that, get out to length. This one, we plated it because it was involving the joint. The forearm, we plated this, so we restored her anatomy. We have this mantra in orthopedic trauma: restore anatomy, restore function. She went back to work. She lives a full life. Here's a gentleman who got bucked off a horse, sustained a very significant proximal humerus fracture. This person was in a motor vehicle accident, sustained this fracture here, a femoral neck fracture. We treated that with plates and screws, but just to show you, sometimes you can reconstruct things and this doesn't go well. Patient didn't heal it. This is called cutout. So thankfully, there's a thing called a hip replacement, and we just give them a new hip. This person got back to living a active life. This person had an unreconstructible proximal humerus fracture. Here's another example of a joint replacement for an upper extremity. So when it comes to injuries, fractures are the most common outcome of an injury requiring treatment. Why am I talking about this? Because it shows you the impact that treating fractures can have on people. By the way, if you guys have to leave. What time do you guys have to leave by? Yeah, for sure. You're not offending me at all. Thanks for coming. What time do you guys have to get out of here?
Yeah.
12:50. Okay, all right. Let's get along. So some things that you need to understand. What are the effects of untreated orthopedic trauma? That femur fracture, what do you think the mortality rate of somebody who has a femur fracture is if we don't treat it? Mortality rate's 80%. Just from that one fracture. So you don't see people dying of femur fractures typically because we treat them. But if you don't treat it, 80% chance of death. This right here, this fracture, an open tibia fracture. What do you think the mortality rate of that is? Like 80, 95%. Okay? If you don't treat it. All right? It was said around the time of the Civil War that your chance of survival was better if you fought all 3 days of Gettysburg as opposed to if you sustained an open tibia fracture and were treated in a public hospital in America at the time. That is how often lower extremity fractures, open fractures result in death. Now, who knows somebody who's died of an open fracture? We didn't have our first case series of our first case series of open tibia fractures with no mortality in it until like the late 1800s with the introduction of antiseptic techniques. So, yeah, so it's like you don't realize it. We don't think about it. But in a part of the world where they don't get treatment for this, people just die. Just die. And those numbers show, right? 93% of the deaths due to trauma in the world occur in low to middle income countries. Here's somebody who survived treatment of a femur fracture non-operatively, but you can imagine how well they function. Here's somebody that survived a wrist fracture dislocation, but do you think they can do manual labor? Yeah, they can. Do you think they can? If they are trying to support their family, they're going to have a very hard time doing it. So 78% of injury-related disabilities, 78%. So of all the injuries, take all of them together, 78% of the disabilities due to injuries are musculoskeletal related. So musculoskeletal injuries account for a lot of disability. But if you treat it right, overall the outcomes are good. Okay, I'm going to do a brief primer on how you think about orthopedic trauma. Okay, we're just going to go through this really quickly. This is going to be called the tibial plateau fracture. So we're talking about a fracture in this region of the body. So the knee, made up of 4 bones, the femur, patella, fibula, and tibia. Sorry, that came across on there. There's an AP view. Here's a lateral view. It's broken down into a medial tibial condyle, a lateral tibial condyle. This is called the lateral plateau. That's the lateral joint surface. This is called the medial plateau. The lateral plateau is this red line. The medial plateau is the yellow line. It needs to be shaped like that. I'll just tell you. Have somebody come in broken in lots of pieces. One thing you'll ask yourself the first time as a resident when you're putting it back together is, what does this look like? You know, so when you're spending time as you're going through your medical education, it really, if you're going into this field, it really behooves you to know this is exactly what this bone looks like. You just have to understand that, right? So part of our training is just to know what something's supposed to look like. Well, here's the fracture right over here. This is a normal lateral plateau. This is a fractured lateral plateau. You can see it's kind of pushed down, it's depressed. Here's another type of plateau fracture. You can see, look at this, the knee alignment's off. You can see this lateral plateau is not lined up with the femur here. So this can be considered a knee dislocation. You cannot walk on this. You can even lose your leg from this and end up with an amputation above the knee. But treated right, you can get back to doing the things you did, right? So this is called a medial tibial plateau fracture. And this one is due from a pure axial load. You broke off both your plateaus. Okay? Do that. So, what's the force that causes this? For a lateral plateau fracture, that type of force can cause that type of fracture. Do that. And you'll end up with a crooked, at the very least, a crooked knee, a crooked, painful knee that's unstable. For a medial plateau fracture, it's a laterally directed force. You can see that it's got shoved everything over laterally. Causes a bow-legged deformity, right? An unstable knee. And for the bicondylar, a lot of times it's this. You can see you have that downward force and it just splits it. What's the advantage of knowing that? If you know that, if I know that something squashed this, what happens if I just pull on it? I'm just going to pull on it with an external fixator. So there's a pin up here and there's a pin up here, and those pins are connected by these bars, which pull the patient out to length and do this. That, it's pretty simple. It's not too hard to extrapolate to another part of the world. That's almost normal now. And then you add to that So plates and screws to make that precise. Now you got a recipe for a good outcome. And that knee can last that patient the rest of their life, and they can get back to doing what they did before. Here's a young man, motorcycle accident. He had a popliteal artery injury along with this. College student,
Come on back, Matt.
riding a motorcycle.
Matt Morelli sustained a bicondylar tibial plateau fracture. He's approximately 11 months out. Okay.
And that, kind of an embarrassing x-ray. This was early in my career. There's a lot of metal in there, but that's what it took to put this back together. Took several hours, but it gives him back the rest of his life. It's impact, what you want. If you look, I'm going to talk about my own profession. If you look at the happiest physicians, orthopedic physicians are some of the happiest physicians. Let's tell you. And I think this is one reason why. So here's another gentleman. He was sleeping in the sleeper part of a semi, and it flew off a bridge and burst into flames, and both his legs below the knees were just burnt. He had this fracture up here. We reconstructed that for him. Here he is 12 weeks out with bilateral below knee prosthetics. This is just demonstrating the walk. He had 9 children. He has to support his family. It was primarily lower extremity fractures. And remember,
Get close up there. Yeah.
no medical treatment, those children would have lost their father. Right? He could walk. From a semi that burst into flames flying off a bridge.
All right, now you can wave goodbye.
Not perfect, right? But it's something. This gentleman got his arm stuck in a PTO. And it yanked his arm, caused a popliteal artery injury, broke his scapula apart, he reconstructed it.
Can you raise your hand above your head? Very good. Bring it down. Good. Can you put your hand behind your back? Very good.
A little bit short. He did really good. Went back to work. Overall outcomes after serious trauma are good when appropriate trauma and rehabilitation care are rendered. Okay. So I want to take time to show this to you because I think it illustrates. It's kind of you might consider it kind of cheesy, but it illustrates what orthopedic trauma can do. Okay. The whole side. Not. It's just in terms of like that that can happen. I mean, you can do that for your patients. I have patients like that are just like these orthopedic creations. So that's really, you can take people back to that. And that's one side of medicine. You guys are going to get exposed to a lot of aspects of medicine, but it shows you the impact you can have on people's lives. But the other thing that we noticed about this is that had this happened in Ethiopia, that person would probably die more likely than not. Do we matter more than Ethiopians? I don't think so. If you're in medicine, you value human life. Where does medicine's borders stop? They don't stop at the state border. Medicine extends to wherever humanity's at, right? So I just did it with this slide. This is Denise and Stan Wood, both patients of mine, and they own this place in Leavenworth, Kansas, where they make tree houses where people can spend, just some time, weekend in a tree house out in the woods. My wife and I did this last year. That tree house to the top. Last year was a really fun time. But he had an acetabular fracture that he sustained when he was making this place. So they had enough money, they bought it, but he had to make these tree houses. We put them back together. He was able to finish this up. And they invited us to come out there, and we went out there, and they told us about the impact that this had had. And they said an interesting thing about this place that she didn't anticipate was there were two women that had come out there alone, and she went and talked with them, and both of them were planning on committing suicide there. And she said that she was able to basically kind of get them help and prevent that. And then they've had like a couple people meet out there. There's like a central greeting place. They've had a couple people meet out there and fall in love and get married. So, it's just like the ripple effect, right? You don't think, it's like when you save a life, or not even necessarily save a life, but when you help somebody stay active and fulfill their dreams, the impact of that, like that downstream effect. So it's just a feel-good thing to end on. But it just shows the impact that this particular field can have. And so the next lecture that we do is going to be talking about, what is the African Trauma Initiative, which is kind of this thing that's going on at KU, where we're partnering with universities in Africa to help train people on how to do orthopedic trauma and why we think that can have an impact. I think everybody's got to go now, right? So thank you so much. And then we'll just plan on, if anybody has questions, feel free to stay. We're willing to answer questions, but thank you all so much. So. Yeah, those have to go. Any questions? Receiving. Yes. Yes, you'll be getting an email, and everything else is going to be in the HEP. So, yeah. Thank you. Yeah, for sure. You bet. Thank you, guys. Thank you.
Yes.
How was your
Okay, what do you want me to do?
Yeah. Very.
Oh, thank you.
All right.
We'll start